Hello, welcome to CE Solutions. My name is Caleb Frady. I'm a North Carolina paramedic with a bachelor's degree in emergency medical science. I serve as a full-time EMS educator and a part-time paramedic in a rural county here in North Carolina. There are several different mechanisms and methods that we can use to prevent the spread of communicable disease. It ranges from public education and prevention to using proper hand hygiene, the way that we arrive and respond to calls, how we don and doff our PPE, and even the methods we use to decontaminate our ambulances after a call. I think you all would agree that the nature of a pre-hospital provider's work is very personable and most often occurs in someone's home when they feel like they have no one else that they can call, and they call us to come and help. So with that, that puts us in a unique position to influence public health and the safety of the public in general. Now, if we look at what's called Healthy People 2020, this is a national initiative that outlines the issues that are affecting Americans today. One of the chapters within Healthy People 2020 looks at infectious diseases, and it gives us a progress report of areas that we're meeting expectations and areas that are getting worse. So if we look at things that expectations that we have met, we see that the spread of tuberculosis, pertussis, and C. diff seems to be decreasing, and we've met those objectives. But something like hepatitis A is getting worse. So with that, when we consider that there's still areas that in regards to infectious diseases that need to be improved upon, that gives us several different methods that providers can use to help educate the public. This may involve being a messenger of important public health information from local, state, and federal jurisdictions, having a presence in the community, specifically underserved communities, being involved on social media so that people may see this education that otherwise might not, um, participating in community events, providing education to those events to as many people as possible. And it may even involve providing education on immunizations and administering those vaccinations to people who wish to receive them. This also brings us into the discussion of community paramedicine. Over the past 5 to 6 years, we've really seen an expansion of these programs. And community paramedics have multiple different functions and roles within an EMS system that include follow up with a patient after they leave the hospital, managing chronic diseases, connecting them into the healthcare system with a primary care physician, etc., providing personalized care in someone's home. That includes providing medical education, education on infectious diseases that they may be susceptible to, and even education on immunizations and providing those vaccinations inside someone's home. These are all ways that as paramedics we can increase public health education in the communities that we serve. Prevention through vaccination is a crucial element in creating herd immunity. This allows us to protect patients who have a high risk of mortality from infectious disease. This includes children, the elderly, and immunocompromised. In general, adults over the age of 18 have a low compliance rate with vaccinations. If you look at something like the Tdap vaccine, specifically pertussis, which is whooping cough, 43% of adults have received their Tdap vaccine within 10 years. If you look at the data from 1980 to 2019, cases of pertussis have been steadily increasing. This is largely due to diminishing immunity among adults and unvaccinated children. In 1980, there was 1,730 cases of pertussis. In 2019, the number of cases had risen to over 18,000. Other areas we can see low vaccination rates among adults include COVID-19 with 22%, seasonal flu 48%, and even pneumonia with a 23% vaccination rate. Something like pneumonia causes a lot of mortality and disability in our country today, with over 1.4 million ER visits, and is responsible for 41,000 deaths. There are vaccination success stories, such as measles, mumps, and rubella reports a 90% vaccination rate. Largely as a result of this, in 2019, only 6 cases of rubella were reported. If you look at something like chickenpox, the varicella vaccination is over 90% effective at protecting against chickenpox and shingles. Smallpox was the first vaccine that was created, and now smallpox does not exist in nature as a result of vaccination programs. Vaccines are predicted to save over 23 million lives from 2011 to 2020. In other words, without vaccines, over 23 million people would have died from an infectious disease. Healthcare workers are no exception to low compliance rates with vaccines. In some instances inside of nursing homes, the rates can be as low as 47%. A study done in 2021 surveyed over 800 paramedics in North Carolina, and the endpoint of that was to identify barriers and to assess vaccination rates among pre-hospital providers. What they found was that 74% of providers received the COVID-19 vaccine within the survey, and 67% received the flu vaccine. The biggest endpoint was to identify barriers and obstacles that may prevent someone from being vaccinated. And what they found was that the most common reasons someone did not receive the COVID-19 vaccine or the flu vaccine is because they felt like they didn't have enough information regarding it. They were concerned about the safety and effectiveness of the vaccine itself. The main reasons that someone chose to receive the vaccine included protection of their family, protection of their patients, and they may themselves feel that they were at high risk of mortality due to COVID-19 and received vaccination in lieu of that. This helps us identify that there is a need for increased education among providers and more discussion surrounding vaccinations and what vaccines, as providers, we should receive. The CDC recommends several different vaccines for healthcare workers. This includes the seasonal flu vaccine, which, as previously discussed, has a low compliance rate among healthcare workers, COVID-19, hepatitis B. Hepatitis B in most places is a requirement to either have the vaccine or sign a declination that you do not wish to receive the vaccine. Measles, mumps, rubella, tetanus, diphtheria, and pertussis are also vaccinations that are typically received in childhood, but there may be boosters that are required throughout your life, such as tetanus, which is recommended every 10 years. Other vaccines that are optional include the shingles vaccine, if not previously vaccinated for varicella, HPV. The CDC recommends that prior to employment in a healthcare field, you should receive an initial TB skin test, and then there's no need for another TB skin test unless you have an exposure or you begin to show symptoms of an active TB infection. As always, when determining what vaccinations are right for you, please do your own research, have a discussion with your primary care physician, and make a decision that works best for you. Several different types of vaccines are used to create immunity. Live attenuated vaccines use a weakened form of the agent to produce an immune response. This can lead to a very strong and, in some cases, lifelong immunity to the agent itself. Messenger RNA vaccines, such as the COVID-19 vaccine that came about in 2020, I believe. There's been decades of research regarding mRNA vaccines, and the way that they work is the messenger RNA enters the host cell and transfers its DNA, and this results in the creation of antigens to its specific purpose. In COVID 19, the antigen that is created is severe acute respiratory syndrome, COV2, and this helps to create a COVID 19 immune response. Another type of vaccination that we see is non replicating or inactivated vaccines. These include hepatitis A, B, influenza, human papillomavirus, and even bacterial meningitis. The way that these vaccines work is the pathogen is either killed or made ineffective or modified so that it is unable to replicate. Once it's introduced into the body is still able to recognize the pathogen and create an immune response for it. One drawback to these types of vaccines is they do require boosters, and it may require multiple vaccines over a period of time. Another type is a subunit vaccine. And basically, what these use is they use a protein or another portion of the agent itself to infer immunity in a patient. Toxoid vaccines. This includes tetanus and diphtheria. This isolates a harmful product within the agent itself and offers immunity to that harmful product. So it does not create immunity to the germ itself, only the toxin that is produced by the germ. Hand hygiene is a well established method of preventing the spread of infectious disease. However, the CDC reports that less than half of healthcare workers wash their hands as often as they should. On a busy EMS day, in a 12-hour shift, a provider may need to wash their hands up to 100 times. Couple this with EMS working conditions that providers often face in terms of working in enclosed spaces, lack of time between calls, multiple patients, and in some instances, lack of education surrounding proper hand hygiene contribute to the spread of infectious disease and further exacerbate the issue of low compliance with hand hygiene among healthcare workers. If you're using a hand sanitizer, the technique is to ensure that you rub it into all areas of your hands until completely dry. And please remember that gloves are not a substitute for hand hygiene, and you should wash your hands before and after donning gloves. Alcohol based hand sanitizer is the most effective way to kill germs throughout your shift, and it's something that we should do before and after we make patient contact, and before and after we put on gloves and take them off. Hand sanitizer is most effective at killing germs, with studies reporting a 21% decrease in MRSA and a 41% decrease in vancomycin resistant enterococcus. Both of those are healthcare worker associated diseases that are spread through improper hand hygiene. In addition to that, the studies have found no noticeable change in the rates of C. diff when using hand sanitizer compared to hand washing. Another benefit to hand sanitizer is that it can increase the rates of hand hygiene compliance, whereas one study found a 25% increase in compliance of hand hygiene after implementing hand sanitizer. They also found no significant change in the rates of C. diff. There are still scenarios in which washing your hands with soap and water is indicated. This includes when your hands are visibly soiled with blood or other body fluids, after using the bathroom, before and after eating, and in patients with known or suspected C. diff. The CDC recommends this out of an abundance of precaution, largely due to the theory that C. diff being a spore based bacteria, using soap and water is able to wash off more of the bacteria than using hand sanitizer alone. So, in patients with known or suspected C. diff, it is good practice to use soap and water to wash your hands. To start, wet your hands, work the soap into a rich lather. When washing your hands, you're going to do so for about 15 to 20 seconds. But the CDC reports that the most important thing to remember is that you wash all of the commonly missed areas, such as your fingernails, in between your fingers, and your thumbs. Once you've done that, the next couple steps are to wash your hands off with water, dry them. I would also consider using a paper towel to cut the water off and open the door. 911 dispatch is often a patient's first contact with the EMS system.
As a result, dispatchers have the ability to assist in identifying possible infectious disease and use those resources to better prepare providers for what we may face on arrival. Dispatch is able to target questions in regards to recent travel, onset and type of symptoms, recent exposures, and in some cases, patients that already have a positive test for an infectious agent, such as influenza or COVID 19. Dispatch can also start to provide medical care to a patient and may even advise them to put on a mask if able and meet EMS outside so that we limit our exposure as we move into someone's home. Albright et al. Is a COVID 19 dispatch screen study completed in 2021. The endpoint of the study was to assess the efficacy of a dispatch screen in determining the presence of an infectious disease. Some of the questions that dispatchers would ask patients included: do you have a known COVID 19 exposure? The presence of fever, chills, shortness of breath? Are you a healthcare worker? And have you traveled anywhere recently? They would utilize these questions to help assist providers in being aware of the potential for an infectious disease. The results of this study found a moderate sensitivity of 74.9% and a negative predictive value of 99.3%. So that tells us that patients that answered no to all those questions were extremely likely to not have COVID 19. Patients that answered yes to some of those questions may potentially have COVID 19 with a moderate sensitivity. This showed value in helping providers predict infectious disease, but it did not replace providers needing to do their own screening once we arrive to the patient. Dispatch screening algorithm helping to predict the presence of an infectious disease. This can also help providers select the appropriate PPE. As dispatch moves through a screening algorithm, like the sample algorithm you see on the screen, at certain check marks can recommend the minimum level of PPE that providers should don prior to making contact with the patient. As we arrive to a scene where there's the potential exposure to an infectious disease, there are several considerations that we should take into account. First, we should utilize our own assessment and screening algorithm in conjunction with a dispatch screening algorithm to assess the likelihood that an infectious disease is present. If suspected, we should select the appropriate PPE and avoid patient contact until donning that PPE. Limit the number of providers who are exposed, and in certain situations, we may ask a patient to wear a mask. This is beneficial in diseases that may be airborne, such as COVID 19 or tuberculosis, and even diseases that may be spread through droplet precautions, such as influenza. And lastly, if your unit is equipped with an exhaust fan, you should turn that on. That helps to pull stagnant air out of your ambulance and place it back into the atmosphere.
When choosing the appropriate level of PPE, you can break this down into several different categories. This includes standard, contact, droplet, airborne, and special respiratories. I've combined both of those because they're very similar, and viral hemorrhagic fever precautions. These are the different levels of PPE that you can select for the given situation. And please keep in mind that, like any situation that we encounter as providers, they're dynamic scenes, and anything can change. So as you obtain more information, you may need to select a more appropriate level of PPE. Standard precautions is our universal method of protecting ourselves from infectious disease that we apply to all patients. You have to assume that every patient has the potential to have some sort of infectious agent present, whether we know it or not through a dispatch screening or our assessment. Standard precautions includes, at a minimum level, wearing gloves for each patient encounter, and in certain other situations, you may don additional PPE. If you are intubating a patient, it's good practice to wear eyewear and a mask to prevent any sort of fluids from the airways splashing into your face. A gown may be beneficial in other situations if the patient is visibly soiled with diarrhea or vomit. A gown would be very useful in that situation. Next, we have contact precautions. The goal with contact precautions is to create a barrier between the infectious agent and the provider. Agents that are included in contact precautions include MRSA, C. diff. You can include scabies, norovirus, and even lice into this category. With contact precautions, we are wearing standard precautions in addition to a gown so that there's a barrier between us and our patient. Droplet precautions. Our goal here is to protect our respiratory system from an infectious agent during patient care. In droplet precautions, certain types of viruses may be spread via large droplets that the patient may expel when they cough or sneeze. This includes the flu, mumps, and common causes of pneumonia, such as streptococcal pneumonia. Our PPE and droplet precautions is going to involve wearing gloves, a surgical mask. An N95 mask is optional. That's really dependent on what your local protocols are, and eyewear to protect again against droplets. Also, consider putting a mask on the patient if they are coughing and sneezing a lot to keep their droplets inside the mask and prevent those from spreading throughout the cab of your ambulance. With droplet precautions, patient care considerations include utilizing nebulized procedures only when necessary. Nebulized procedures can allow those droplets to have a vessel to spread throughout the ambulance. And if we don't need to do those types of procedures, we should avoid them. Airborne and special respiratory precautions. I lump these two together because the PPE that you don is very similar with really just one minor difference. Airborne viruses such as tuberculosis, chickenpox, and measles can remain suspended in the air over long periods of time. So the goal with this type of PPE is to protect against the inhalation of those agents as they are found in the air. So with an airborne precaution, we're using standard precautions at a minimum an N95 mask, so no surgical mask with airborne precautions. And if you have access to a PAPR with a hood, you may also wear a PAPR also, and we'll talk about that in a few minutes. And lastly, some sort of full face shield or eyewear. So if you're using an N95, you should have eyewear or a face shield with it. The special respiratory section really just adds the need to place a barrier between you and the infectious agent. So what that means is you are doing a combination of standard, contact, and airborne precautions via the same PPE, just including a gown. Another consideration with special respiratory precautions is, again, consider a mask for the patient. Utilize your exhaust fan in your ambulance. You can even open windows if you have access to that. You can also consider closing off the ambulance compartment if you have a door in between the ambulance and the driver's compartment. And if you have access to it, if you're ventilating a patient, utilize a HEPA filter. This can help filter out those infectious agents if you're ventilating a patient as they're leaving the patient's airway. A PAPR device. It's a full face hood that protects your head, face, and neck from droplet and contact precautions, in addition to providing filtered, purified air. So the way that a PAPR works is it has some sort of battery component that has a filter, most likely a HEPA filter cartridge in it. And then that battery component will suck in air through the air filter and through a hose, pump that air into the face shield or the hood that you're wearing. So a couple good benefits of that. It's more comfortable to wear over periods of time as you get constant fresh airflow. It's not affected by facial hair, so those of us with beards can utilize a PAPR and still be able to respond to infectious disease situations that may require an N95 mask. With an N95 mask, some of the disadvantages to it, where it does require initial and periodic fit testing, can also be a heavy cost burden and over time for EMS agencies as they have to stock different sizes of N95s. And in certain cases, like we've seen during COVID, there was a limited supply of N95, so you were really trying to triage your use of those. N95s also have just a poor tolerance by the user. If you've ever worn one for a period of time during a call with eyewear and things like that, then you know that it gets very hot underneath the mask, and it's hard to breathe through the mask too because of how tight it fits to your face. With a PAPR device, it's a little bit easier to breathe and work in that situation. But like any piece of equipment we use, it does have limitations. Some of the disadvantages to a PAPR device is it does require a battery. In certain cases, they can be a little bit noisy. And then also, if you do not check your battery throughout your shift, you run into a situation where it may be dead right before you need to use it. With Certain PAPRs with a full face shield and a hood, you may not be able to use a stethoscope, which for us as providers, that might be a significant concern when needing to listen to lung sounds, listen to a blood pressure, listen to heart sounds, and other things like that. And PAPRs are pretty expensive initially. So for a large EMS service with 100 plus employees, it can be very difficult to provide a PAPR for each employee. Our last level of PPE is viral hemorrhagic fever. This includes Ebola as the primary one. This is extremely, extremely rare, and most patients you come into contact that you may suspect viral hemorrhagic fever most likely do not have that specific disease. But in the setting of a confirmed viral hemorrhagic fever case, our PPE is at the highest level that we have available. This is going to include, at a minimum, 2 pairs of gloves, and specifically gloves that have a longer wrist so that you can don the first pair of gloves, place your gown on, and then the second pair of gloves will go over top of all that so that there's no entryway for any sort of disease such as Ebola to come into contact with your skin. It's going to include an N95 or a PAPR and a full face shield. Because this Ebola viral hemorrhagic fevers are spread by direct contact with the patient's body fluids, we really need to have the most robust protection of our PPE as we can get. It's also going to include boot covers and a full sleeve gown. In most situations, if you have like some sort of Ebola kit in your units, the gown is going to be thicker. In a viral hemorrhagic fever case, the more body fluid there is, the more or the increased risk of transmission. So our goal is to keep those body fluids contained. This may involve putting a barrier around the patient, such as placing them in PPE, a mask, gown, gloves. Utilize IV access only as needed in these situations because, again, doing those types of procedures exposes us to the patient's skin and possibly their body fluids. And notify the hospital early. This gives the hospital or your destination the ability to prepare a room, have their PPE donned, especially in the situation if you have a critical patient that you're bringing in with viral hemorrhagic fever. You really want to do this so that there's not a delay in patient transfer while you're waiting for PPE to be donned and doffed and those types of things. General donning and doffing of PPE considerations. There's multiple different ways that you can don and doff your PPE. The main principle is that you're doing so in a safe manner and you're avoiding cross contamination while you're doing so. Also, be sure to use hand hygiene very frequently during the process of donning and doffing your PPE. The general order to don PPE includes starting with a gown, mask, eyewear, and last, donning your gloves. When doffing your PPE, the order should follow gloves, gown, eyewear, and then mask. Keep in mind that your gloves and your gown can come off at the same time and be placed into a trash can. Having some sort of checklist or procedure that you can reference during the donning and doffing process is helpful in safely removing your PPE. And keep in mind that when doffing PPE, it needs to occur in the appropriate area. So if you drop a patient off in the hospital, you should doff your PPE before leaving that patient area so that you avoid contaminating any areas as you leave the patient's room. Also, avoid touching unnecessary things as you move from the ambulance compartment into the hospital, as everything that you touch can potentially become a contaminated surface. So if you don't need to touch it with your gloves on, don't do it. Utilize an additional provider that may not have to be in the full PPE to open doors and move through the hospital for you while you're involved in patient care. When donning PPE, start by removing any personal items such as a watch and pulling your hair back. Our gown is donned first. Ensure that it covers your torso and your waist, and if needed, utilize a trained assistant to tie the neck and the waist straps. When selecting your mask, if using an N95, ensure that you have a flush fit on your face and that there is no air leaking out of the sides. Once you have done this, the top strap is then pulled over top of your head and should rest just above your ears. The bottom strap is then placed at the base of the neck and ensure a proper fit one more time. When you're placing your eyewear, whether it's goggles or a face shield, be careful not to touch the front so that you have no issues with vision. The last couple steps here are to perform hand hygiene one more time and don your gloves. Keep in mind that as you place each individual item, you should be inspecting it for any compromise, such as a tear or a hole.
For the glove and glove technique, pinch the outside of the glove near the wrist. Peel downwards, pulling the glove inside out. With your ungloved hand, slide your finger under the wrist of your remaining glove. Again, peel downwards, turning the glove inside out. Discard the gloves. Next, remove your gown. Untie all ties or unsnap all snaps. Some gown ties can be broken rather than untied. In that instance, break the ties gently, avoiding a forceful movement. Reach up to the shoulders and carefully pull or roll the gown down and away from the body. Dispose of the used gown. You may now exit the patient's room. Carefully remove the face shield or goggles by grabbing the strap and pulling upwards and away from your head. Do not touch the front of the face shield or goggles. Next, remove and discard the respirator or face mask. If you are wearing a respirator, remove the bottom strap by grabbing only the strap and bringing it carefully over your head. Grasp the top strap and bring it carefully over your head, and then pull the respirator away from your face without touching the front of the respirator.
Decontamination is an important step in preventing the spread of infectious disease. This is something that we should make a good habit of and clean the ambulance when we start a shift and when we leave at the end of the shift, in addition to cleaning the unit after each patient encounter. MS1 did a study or a survey where they asked respondents how often they clean their ambulance. And what they found was that less than half of the time, those respondents reported that they clean the ambulance before and after a call, and 8% reported that they never do this. This is concerning when you account for ambulances and healthcare facilities being a known breeding ground for healthcare acquired infections such as C. diff and MRSA. When manually decontaminating your ambulance, you should start by donning the appropriate level of PPE. If you are transporting a COVID-19 patient wearing special respiratory precautions, that's the same level of PPE that you should wear while decontaminating your unit. Also, keep in mind that some of the cleaning solutions you may use are not intended for skin to skin contact, so at a minimum, you should always wear gloves while cleaning the ambulance. Start by disinfecting any visibly soiled areas and high contact areas, such as the stretcher, the bench seat, door handles, and doors that the patient may have touched throughout the course of your call. Next, move into your medical equipment. Disinfect anything that you used that is reusable to treat the patient, such as your monitor, the monitor cables, a blood pressure cuff, and a stethoscope. Also, think about things that are commonly overlooked that you may have touched throughout the course of a call, such as a pen, a radio to call the hospital, or even a computer or clipboard you used to begin your PCR. Choosing the appropriate cleaning solution is also important. Certain types of pathogens require a certain type of disinfectant. C. diff requires a hypochlorite solution, which is bleach based. Some other types of sanitizers that you may be exposed to and use in the field include an alcohol based sanitizer. Alcohol based disinfectants have a really good range of antimicrobial activity from viruses to bacteria to different types of fungi. So they're a good all around option to provide decontamination on a daily basis. For an alcohol based disinfectant to be effective, it should at least have a concentration of 60% alcohol in water. Anything less than that, and it may not be effective enough to kill the pathogens that we need it to kill. And the third type that you may be exposed to is a hydrogen peroxide cleaning solution. Again, hydrogen peroxide is also really useful for a wide range of pathogens. Manual decontamination does have some pitfalls. Throughout our nation, we're seeing increased workloads and staffing shortages that can oftentimes make decontamination an overlooked task. In addition to this, Cleaning all areas of the patient compartment after each call can be tedious and time consuming. And most commonly, we miss contaminated areas throughout the process of manual decontamination. Brown et al. Performed a study where they assessed for the presence of MRSA in ambulances, and they found that in 25 out of 51 ambulances, MRSA was present in 16 different locations. And this really just highlights that our standard cleaning practices may not be as effective as we initially thought. Considering the pitfalls of manual decontamination, and the emergence of COVID-19 in 2020, there has been an increased emphasis and a need for better ways to decontaminate our ambulances. Out of this, there are several new technologies that are being utilized throughout the nation to help perform this process more efficiently. The first one I want to talk about is electrostatic sprayers. These have a benefit of being able to be used with a wider variety of sanitizers, and what they do is they electrolyze the particles and spray it into a fine mist. And that fine mist is able to stick to surfaces better and move into cracks and crevices that were otherwise missed via manual decontamination. A study done in a hospital setting using a bleach based solution found that electrostatic sprayers were effective at reducing the amount of C. diff spores present on things such as wheelchairs and hospital beds. The next type is UVGI, which is ultraviolet germicidal irradiation. And what this does is this uses a UV light to help kill pathogens. UV light has been well documented to reduce the level of pathogens on surfaces, and it's something that can be used inside of an ambulance, inside of a station, to help provide continuous decontamination. And that's the biggest benefit with a UV light, is that you can leave it on and it continuously decontaminates. So in the setting of an ambulance, while you're driving down the road with no patient in the compartment or the ambulance is parked at a station, the UV light can be on and decontaminate the back of your ambulance. And then when you do introduce a patient into the compartment, you can cut the UV light off. The biggest disadvantage to UV light disinfection is that the UV light has to be able to see the surface to, to kill the pathogens on it. So it's not really useful in cleaning areas that are behind cracks and crevices or underneath a bag or something like that. The third type is foggers. Foggers typically utilize a hydrogen peroxide based solution to spray that into a fine mist, and that mist travels to everywhere inside of the compartment that it's placed in. The biggest benefit is there's no need to wipe after its use, and it doesn't leave a sticky residue or anything like that. It does require you to open up any compartment so that the mist can get down into it. And the biggest disadvantage is it's not really applicable for a daily use after each call because it does take 10 to 15 minutes for the fogger to release its chemical, and then another 10 or 15 minutes for the ambulance to air out and be safe for you to re-enter. As we come to the end of Pre-Hospital Exposure to Infectious Disease, Volume 1, I would like to end with a demonstration of how infectious disease can be spread throughout the patient compartment and how decontamination practices may not be as effective as we may think. To start this case study, we have a 67-year-old female that we've been dispatched out to for flu-like symptoms. Dispatch performs a screening algorithm and advises that the patient tested positive for flu 2 days ago. As a result of this, we decide en route to the call to go ahead and don droplet precautions. What that means is we are going to, at a minimum, wear gloves, a face shield, and a surgical mask. As we arrive to the residence, we make entry into the patient's bedroom. We find that she's laying in her bed, covered in her own feces and urine. The patient advises that she's had diarrhea for the past 2 days also. With these new findings, we decide to upgrade our PPE and also don a gown so that we are now protected against contact and droplet precautions. The reason that we did this is because the patient was recently discharged from a rehabilitation clinic, which is most likely where she may have picked up the flu. But in addition to that, she may have acquired a healthcare worker associated infection such as C. diff. Now that I have the appropriate level of PPE on for this case, I decide that this patient may need some interventions. Vitals are on the screen here as follows.
It appears that she's dehydrated, most likely as a result of the flu. So I decide that I'm going to start an IV. First, I need to obtain a manual blood pressure. So I get my blood pressure equipment and I obtain an auscultated blood pressure. Next, I'm going to go ahead and proceed with starting an IV. So I start an IV on this patient. I also need to place her on the cardiac monitor so that I can monitor her vital signs throughout the call. I'll also need to reach up in to certain compartments and grab my normal saline and a drop set. I may even have to stand up and hold on to a rail as we move down the road. So you can see there's lots of different things that I come into contact with and that I have to touch throughout the course of this call. This is a lot of different areas and times for me to take an infectious disease that either the patient has visibly sold in their diarrhea, such as C. diff, or some sort of droplet that may come from the airway, such as the flu virus, and spread that to different surfaces throughout the ambulance. Now that we have completed our call and safely transferred patient care, we doffed our PPE in the patient area and are now in our ambulance preparing to decon. Keep in mind that we should don the same level of PPE that we utilized for the call to decontaminate our ambulance. So now let's look at the places within our ambulance that we contaminated throughout the course of our call as we touched our patient and then touched surfaces. So we can see on the IV tray there is some contamination. The floor has contamination. Our stethoscope and our blood pressure cuff look like they took the brunt of it. The rails of the stretcher, the seat belts, pretty much everywhere that I touched with my gloves, that I touched the patient with, has the potential to contain an infectious agent. So I've now decontaminated the ambulance. I used an alcohol-based wipe that you see on the bench seat to clean high contact areas that I touched and things that the patient may have touched. I simulated doing this very quickly, as if the county that you're working in is low on trucks, short on staff, and needs to be available within the next couple minutes to run a call. The rail still has some contaminants that I missed from wiping. The floor, I skipped the floor because I didn't mop it. Even my blood pressure cuff and stethoscope still have potential pathogens on them. And the IV tray looks like I'd never touched it. From this experience, I hope you can see how easy it is for us to overlook infectious disease and put ourselves at risk and our patients, especially those that are at a higher risk of mortality from an infectious pathogen. Thank you for watching Volume 1. In Volume 2, we will discuss specific pathogens and their presentation. Thank you.